regardless of what kind of practice you're in, count on payment rates going down. And that means that we're going to have to start figuring out how to be more efficient if the payment rates decline. And we may have to actually see our own incomes go down. I think that is a potential consequence of all this stuff. Freestanding practices, I think, are going to find survival a challenge. They already are in many cases. The best estimate I've seen, by the way, of how many physicians work for hospitals came out of American Hospital Association survey of their members in 2011. And they, for the first time, asked hospitals, how many physicians do you employ? And if you took the responses and extrapolated it to the overall universe, it's about 25% of the practicing physician population as of last year were employed by hospitals. That number, nobody knows exactly what that number was 5 years ago, but I know it was less. It's been going up pretty steadily. Will we ever see all physicians employed by hospitals? Probably not. In fact, there are some specialties, I mean, why would a hospital want to employ dermatologist, allergist, psychiatrist? And they don't generate revenue for the hospital. And generally, when hospitals employ physicians, they lose money on those employed physicians. So I think there's some specialties they have no appetite for employing. But others they will probably continue to try to pick up. And I think there are going to be more physicians who are going to continue to go to the hospital and say, I'd like to go to work for you, simply because of the stresses of trying to keep a freestanding practice afloat. High-cost chronic conditions are going to be a major target for cost reductions. And that's where this hits home for nephrology, because you deal with high-cost chronic conditions. And that makes you, in a way, have a target on your back. I pulled a couple of numbers up off the web just to see how much does Medicare spend on ESRD care. And I'll share a couple of numbers with you. These are from 2008. Everybody knows Medicare's data always lags several years behind. But chronic kidney disease diagnosis codes are found at about 9.5% of the Medicare population. And those patients account for 31% of total Medicare cost. So a third of the Medicare expenditures are for patients who have chronic kidney disease as at least a diagnosis code. Another one is that 25.6% of Medicare patients have diabetes as a diagnosis code. And patients with diabetes account for 41.2% of total Medicare expenditures. Obviously, there's a lot of overlap between those two populations. Many of your patients with ESRD have that condition because of their pre-existing diabetes. But what that does, if I was sitting in Medicare and trying to figure out how to reduce cost, if you want to target it, targeting it on improving care and reducing hospitalizations for patients with diabetes or patients with chronic renal disease would be a high priority target. That's, in that sense, it can't help but have an impact on nephrology care. The flip side of that is if you can demonstrate that you are doing a good job, it's a huge opportunity. It's like a lot of things in life. On the one hand, it could be a threat because it's obvious that the crosshairs will be on patients with chronic illnesses. But practices that can demonstrate their effectiveness in safety, quality, cost effectiveness, and patient satisfaction, we're going to have a real opportunity to pick up more market share and to be the preferred providers going forward. The fourth impact that I think we're going to see is at least part of the payment is going to be at risk. There's a part of what the ACO thing is really all about is trying to transfer risk off of the payers and onto the provider organizations. Will that be bundled payments? Will it be a return to capitation? I think it'll be probably some of all of those things, depending upon your market and the payers. But without question, what you make is going to be driven by how you do on metrics of safety, quality, cost efficiency, and patient satisfaction. I think chronic disease management expertise will be in increased demand, which again, I think positions nephrologists who are skilled in managing those patients with chronic disease to be in a very desirable position. And I think every accountable care organization is going to want, if patients are being assigned to these ACOs by Medicare, and I'm talking right now about the Medicare ACOs, because that's really where most of your patients are, that's where a lot of the cost for these Medicare ACOs is going to be centered. They're going to want to have access to the best renal disease care that they can, because that's the only way they'll be able to demonstrate some savings and make some money. Several parts of the country, I've seen specialists starting to form not their own ACOs, but their own network that they are marketing to ACOs. Up in the Northwest, there's a group of rheumatologists that have formed a network that actually cuts across Oregon, Washington, Idaho, 3 or 4 of the states up in the Northwest. And they all use the same patient functional assessment tool. And they've got good longitudinal data on the functional status of patients in their rheumatology practice. They market their network. And the practices that are in the network are not in the same community, so they're not competing with one another. They're in different communities. But they market their network to all the health plans, and they use their functional status data to show that if you contract with our network, we've got the data to demonstrate we are more successful in maintaining functional status amongst our patients. That puts them in a position where every ACO that's forming is going to want to contract with their network for rheumatology care, because they've got the data to demonstrate that they're the best in that particular field. So I think there's some real opportunities for nephrologists to do similar kinds of things.